Environmental conditions are a core responsibility for athletic trainers. Emergencies like heat stroke are highly preventable with proper planning, acclimatization, hydration, and environmental monitoring. Exertional heat stroke is a true emergency, requiring immediate attention.
Our learning objectives are to differentiate heat illness categories, understand why rapid cooling is vital for exertional heat stroke, and recognize conditions like hyponatremia, hypothermia, sickling collapse, and altitude concerns. We will also cover prevention planning essentials. Heat illness exists on a spectrum. Mild symptoms include heat rash and cramps, requiring monitoring. Moderate symptoms, like heat exhaustion, involve dizziness and clammy skin. Life-threatening heat stroke is defined by CNS dysfunction and dangerously high core temperature. When exertional heat stroke is suspected, follow the cool first, transport second protocol. Recognize collapse and CNS signs, obtain a rectal temperature if trained, and immediately initiate cold water immersion. Monitor vital signs and airway until transport is safe.
The key difference between heat exhaustion and heat stroke is the presence of altered mental status, or CNS dysfunction, in heat stroke. If uncertain and heat stroke is possible, begin aggressive cooling while activating EMS. Do not delay cooling for logistics. Other environmental emergencies include hyponatremia, a risk of overhydration, presenting with confusion and headache. Hypothermia requires removing wet clothing and rewarming. Sickling collapse involves unusual fatigue or dyspnea, demanding cessation of activity and activating your emergency plan. Prevention systems are critical. Implement heat acclimatization and progressive conditioning. Monitor environmental risks and modify activity accordingly. Ensure plans for hydration, shade, rest breaks, and cold water immersion access are in place. Educate athletes and coaches and rehearse your emergency action plan. Consider this case. During practice, an athlete collapses, is confused, and feels hot. An ice tub is ready. The primary concern is exertional heat stroke. Rectal temperature is the most accurate method if trained. Immediate action is cooling before transport. The clinical takeaways reinforce that CNS changes in the heat are a red flag. For suspected exertional heat stroke, cool first and transport second when possible. Remember that hyponatremia is not dehydration. Effective prevention begins long before practice starts.